In today's lecture, we will discuss the spinal cord and its diseases. Before moving on to the lecture, please know the segments of the spinal cord. So, in the spinal cord, there are 5 segments: cervical, thoracic, lumbar, sacrum, and coccyx. There are 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar vertebrae, 5 sacral vertebrae, and 4 coccygeal vertebrae. The last 2 vertebrae, that is sacral segment and coccygeal segments, the vertebrae are fused together. And also know the location of these segments. It will be helpful in knowing the clinical features. Please use the mnemonic CTLS to remember the segments of the spinal cord later. So we have C7, T12, L5, S5, C4. In today's lecture, we will discuss various cases and their related clinical features. In the first case, there is a lesion in the anterior horn of the spinal cord. If you have reviewed my ascending tract of spinal cord video lecture and the lecture notes, you would have known the parts of the spinal cord. Now, in a spinal cord, you have white matter and gray matter. So, the gray matter near the sensory area, that is near the dorsal column, is known as alar plate. The gray matter near the motor area is known as basal plate. And also know that you have anterior horn, dorsal horn, lateral horn. So now the lesions are present in the anterior horn. So what is a lesion? A lesion is an overgrowth or extra growth in an organ or in a tissue inside the body or outside the body. So if there is a lesion, it will disturb the normal functions. Now you know, in the anterior horn, you have the motor nerve fibers coming from the spinal cord going to your body. So if there is a lesion in this anterior horn, the normal function of the motor nerve fibers, it will be disturbed. In this case, there are bilateral lesions in the anterior horn. So now you know there is a motor lesion. Now whether this is a lower motor neuron or upper motor neuron lesion, how will you determine this? Upper motor neuron means the neuron that are the nerve fibers coming from your cerebral cortex of the brain to the spinal cord. Lower motor neurons are the nerve fibers coming out from your spinal cord to your body. So in the anterior horn, the nerve fibers coming out from the spinal cord to your body, so they are known as lower motor neurons. So the lesion is in the lower motor neuron, so known as lower motor neuron lesions. So this lesion is caused by a virus known as poliovirus. This is a type of enterovirus. You can see this virus from the gastrointestinal tract. This poliovirus has higher affinity for anterior horn cells, that is, this poliovirus love to affect these anterior horn cells. This poliovirus, not only it will affect the cells in the anterior horn, it will also affect the motor nerve nuclei in the brainstem. In the ascending tract of spinal cord lecture, I have discussed about various nuclei in the brainstem. So what is this condition? This condition caused by poliovirus in the anterior horn of the spinal cord is known as poliomyelitis. So the clinical features you see in the poliomyelitis are muscle atrophy, loss of power, hypotonia, reflexia, fasciculations and fibrillations. What is muscle atrophy? Atrophy means decrease in size. Decrease in size of the muscle is known as muscle atrophy. Here you can see this is a normal muscle, atrophied muscle. Loss of power, it is a self-explanatory. There is loss of power in doing the daily activities or lifting any things. Hypotonia, so tone. In a normal muscle there is some rigidity and stiffness for the muscle. If there is no rigidity and stiffness, there is no tonicity. What happens? The muscle will become floppy. The muscle become floppy, that means the muscle will be completely relaxed. You can see the complete relaxed state only during sleeping or in a dead person. Hypotonia, so in a normal muscle there is stiffness and tension in the muscle. If there is no stiffness and tension in the muscle, then the muscle it will be floppy. Floppy means completely relaxed state. You can see this completely relaxed state of the muscles only in a dead person or when the person is sleeping. Then hypotonia in poliomyelitic patients, especially in infants, you can see this hypotonia. And then we will move on to reflexia. How do you test a patient's reflex? In order to test a patient's reflex, use a hammer and tap it on the patient's knee. If there is a jerk movement, that is movement of the legs, then the patient has normal reflexes. If there is no response, then there is areflexia, that is absent of reflexes. If there is over response, then the patient has hyper reflexes. Then fasciculations. So what are these fasciculations? Fasciculations are muscle twitches. So I think many have felt this pulling of muscle from inside after a long walk or after cycling or leg workout. This is known as muscle twitch, and many felt commonly in the thigh region. So these muscle twitches, fasciculations, not only caused by poliomyelitis, it is also because of low magnesium, that is magnesium deficiency also. Then fibrillation is concerned with the your heart, that is irregular heartbeat. In poliomyelitis, there are bilateral lesions in the anterior horn of the spinal cord. That is, the patient has lower motor neuron lesion, and the respective clinical features are muscle atrophy, loss of power, hypotonia, areflexia, fasciculations and fibrillations. In the next case, the patient is 6 months old with a family history of this problem. So family history means either the parents or any of the family members have the same condition before, and this is a progressive problem because the patient are before first year of life, that is below 1 year of age. This condition is known as progressive infantile muscular atrophy. So what is a progressive problem? Progressive problem means the conditions, it will become worsen day by day if not treated. So this condition is also known as Wernicke-Hoffmann disorder. So why this name progressive infantile muscular atrophy? Progressive, it is because of the worsening of the condition in this patient. Infantile, since the patient around below 1 year of age, and muscular atrophy, the lesions are in the anterior horn, so it will disturb or affect the lower motor neurons. If the lower motor neurons are affected, then there will be muscle atrophy. Then we move on to the next case. The third case, it is same as the second case, except here the patient is older age group, and the patient also has family history. So this condition is known as juvenile hereditary lower motor disease. Juvenile means adults, and hereditary, the patient has a family history. Lower motor disease, the lesions are in the anterior horn affecting the lower motor neurons. This condition is also known as Kugelberg-Wallander disease. In the next case, fourth case, in the first three cases, the lesions are in the anterior horn affecting the lower motor neuron. In the fourth case, the lesion affecting the upper motor neuron. So what is this upper motor neuron? Upper motor neurons are nerve fibers from the brain, cerebral cortex of the brain, to the spinal cord. So corticospinal tract, I have not discussed this corticospinal tract yet, because this comes under descending tract of spinal cord lecture. So this corticospinal tract, it is from the cerebral cortex of the brain to the spinal cord. If the lesions are present in the corticospinal tract, then the information from the brain to the spinal cord, it will not pass further. So here there is a upper motor neuron type of lesions. The patient will have spastic paralysis, hyperreflexia, Babinski sign which is upgoing, and the clonus are present. The lesions are bilateral, are on both the sides of the corticospinal tract, and because of these lesions, there will be bilateral degenerations of the nerve tract. Now, what is this spastic paralysis? Spastic paralysis means after a paralytic attack in a patient, if the patient has high stiffness or high tension in the muscles of any of the limbs, it is known as spastic paralysis. As you can see in the picture, the patient has a flexed elbow, bent wrist, pronated forearm, clenched fist, and thumb in palm. So this is a spastic paralysis. Spastic paralysis you see only in upper motor neuron lesion. Flaccid paralysis you see in lower motor neuron lesion. What is a flaccid paralysis? Flaccid paralysis means after a paralytic attack, the patient will have a relaxed, completely relaxed state of the muscles. Like you can see here, the limbs are completely relaxed. There is no stiffness or tension. Example of a poliomyelitic patients. Hyperreflexia, I have discussed this earlier. The reflexes are over responsiveness in this patient. Babinski sign. What is a Babinski sign? If you stroke with a pencil or any object under the patient's, under the sole of the patient's foot, if the toes of the patient, if they go downwards, then it is normal. If the bigger toe, it goes upwards and the remaining toes, it goes downwards, then it is abnormal, and it is known as positive sign for Babinski sign. And please note that this abnormal Babinski sign is normal until age 2. So until age 2 and below age 2, this Babinski sign is a normal, considered a normal. But If this continues even after age 2, then it is abnormal, and you can also rule in upper motor neuron lesion. So Babinski sign, which is upgoing, means here the bigger toe is going upwards, so going. Here all the toes are going on the opposite side, so here the Babinski sign is down going, or you can say there is swaying of the toes. Then clonus. So what is a clonus? If you put pressure in the foot of the patients, then what happens is there will be involuntary rhythmic contraction and relaxation, like jerk movements in the ankle area. So this is known as ankle clonus. So if there is involuntary movement, that is with the rhythmic pattern, that is with the same pattern going upward, going downward, then this is ankle clonus. You can see this condition in upper motor neuron lesion. Fasciculations are absent in this condition. So this condition is known as hereditary spastic paraplegia or diplegia. Why hereditary? Because this condition also has, the patient has a family history, and spastic, the upper motor neurons are disturbed or affected by the lesion, so there will be spastic paralysis, paraplegia or diplegia. Please know that paraplegia means the lower limbs, that is the patient's legs, are affected. Diplegia means either the lower limb or the upper limbs, either the legs or the arms are affected. Quadriplegia means all the four limbs are affected. Hemiplegia means one arm and one leg on one side of the body is affected, the other arm and other leg work normal. Let's move on to the next case, fifth case. In the fifth case, the lesions are in both the upper motor neuron and lower motor neuron. If the lesions are on both the upper motor neuron and lower motor neuron, then it will involve multiple muscles, and the patient will have the respective clinical features according to upper motor neuron and lower motor neuron. So this condition is known as motor neuron disease, since it involves both the motor neurons. This condition is also known as amyotrophic lateral sclerosis. Amyotrophy means wastage of muscles or muscle atrophy. Amyotrophy because of the involvement of lower motor neuron. Lateral sclerosis, it is because of the involvement of upper motor neuron. Let's see the next case. In the next case, the lesions are in the fasciculus cuneatus and fasciculus gracilis tract. If you have reviewed my ascending data spinal lecture, you know the location of fasciculus cuneatus and fasciculus gracilis tract. They are in the dorsal column. If there is a lesion on one side of the fasciculus cuneatus and gracilis tract, then the one side dorsal column sensations are disturbed. One side, I mean, there will be ipsilateral loss of dorsal column sensation, since the sensory nerve fibers, they enter the spinal cord from the body to the spinal cord and moves upwards on the same side. They do not cross. So if there is a lesion on right side of the body, the clinical features will be seen on the same side of the body. It is known as ipsilateral, and the opposite is contralateral. So what are the dorsal column sensations? 2-point discrimination, that is tactile discrimination, fine touch, sense of position and sense of vibration. And also please note that this is a demyelinating disease. So what is a demyelination? Demyelination means loss of myelin sheath. A myelin sheath is the protective covering of the axon of a nerve fiber. So in this condition there will be demyelination. And also note that there will be normal functions of the anterolateral sensations because the lesion is only on the dorsal column. So only the dorsal column sensations are disturbed, not the anterior or lateral column sensations. So there will be normal crude touch, pain and temperature. This condition, the patient also present with the Romberg sign. So what is a Romberg sign? The patient can maintain his balance. Balance, I mean the balance of his body, the balance of his head with his eyes open. But if the patient, once he closes his eyes, he may lose his balance, he may fall down. This is known as Romberg sign. So why this is happening in this condition? It is because, please note that your sense of position, that is the position of our body, the position of our head, basically depends on three informations: visual information, vestibular information and proprioceptions. So these informations are controlled by the central nervous system. So if there is a defect in any of these informations, for example, if there is a defect in vestibular informations and the patient has a good visual information and good proprioception, the patient can still able to maintain his balance. If there is a defect in the proprioception and the rest of the informations are working normal, then the patient can still able to maintain his balance. But if there is a defect in the visual information but the vestibular information and proprioceptions are working normal, then the patient cannot balance his position. It is because visual information is very important. And also know that cerebellum is your headquarters of coordination of movements. So visual information is very important in all cases. Because of this visual information, you know your position of your body and also know your position of your head. Vestibular information, the information from your inner ear. In your inner ear there are a sensory system which helps in maintaining the balance of your head. This proprioception I have discussed in the ascending tract of spinal cord lecture or in the respiration lectures before, the function of a proprioception. This condition is known as dorsal column syndrome. So here is a 2-point discrimination example, and here is the example of a reflex test. Then we move on to the next case. In the 7th case, the patient has a lesion in the lateral spinothalamic tract. So please know the pathway of this lateral spinothalamic tract. In this tract, the sensory nerve fibers, it enters the spinal cord and it crosses, then it moves upwards. So if there is a lesion on the right side of this tract, what happens? If there is a lesion in the right side of this tract, what happens? The clinical features, it will be seen on the other side. So this is known as contralateral. But in dorsal column, the sensory nerve fibers, it enters the spinal cord and moves upwards on the same side. So if there is a lesion on the right side, the clinical features, it will be seen on the same side, that is known as ipsilateral. And also know the lateral spinothalamic tract function. The function is pain and temperature. So if there is a lesion on the right side, then there will be contralateral loss of pain and temperature. I have discussed all this in ascending tract of spinal cord lecture. So here is the lateral spinothalamic tract. Then in the eighth case, there is a lesion in the anterior spinothalamic tract. The sensory nerve fibers, they enter the spinal cord and they cross on the anterior side and they move upwards. So here also there is contralateral loss. The function of anterior spinothalamic tract is crude touch and pressure. There will be contralateral loss of crude touch and pressure. And please note that in the 7th case and the 8th case, in the 7th case, that is the lesion in the retrospinothalamic tract, the clinical features, it will be seen from the next spinal cord segment, that is one segment below the lesion. Here in the 8th case, that is the lesion in the anterior spinothalamic tract, the clinical features, it will be seen from the 2 to 3 spinal cord next to the lesion spinal cord. So the 3 to 4 segments below the level of lesion. Below the level of lesion means here is the lesion in the spinal cord. So below the level of lesion. So it will be seen from 3 to 4 segments below the level of lesion. In the 9th case, the lesion is in the dorsocerebellar spinal pathway. Please know the pathway of dorsocerebellar spinal tract. The sensory nerve fibers, they enter the spinal cord and they move upwards on the same side. So there will be ipsilateral loss. If the lesion is on right side, then the clinical feature, it will be also on the same side, that is right side. So dorsocerebellar pathway, I have discussed this earlier. Cerebellum is the headquarters of coordination of movements. So there will be ipsilateral loss of coordination of movements. So if there is a disturbances in the coordination of movements, if there is a severe disturbance, it is known as ataxia. A milder form of ataxia is known as dystaxia. So in this condition, the patient will have a lower limb dystaxia. So here is the dorsocerebellar spinal pathway. This one. Then in the next case, the lesion is in the anterior spinocerebellar pathway. So first see the anterior spinocerebellar pathway. Where is this anterior spinocerebellar pathway? Anterior, also known as ventral. So here is the anterior cerebellar spinal pathway. The sensory nerve fibers, they cross and they go upwards. Ventrospinal cerebellar pathway, also known as anterior spinal cerebellar pathway. So the clinical features, it will be contralateral, and anterior spinocerebellar pathway also concerned with the coordination of movements. So if the lesion is on the right side, the clinical features, it will be seen on the left side, that is left side lower limb dystaxia. One may ask a question, why lower limb dystaxia and why not upper limb? Please know that dystaxia means disturbed in the coordination of movements. Coordination of movements is basically you move with the help of your legs. So coordination of movements are concerned with your legs. So the clinical feature, it will be seen only on the lower limbs. In the next case, the lesion is present on the dorsal root. I have discussed this in the ascending spinal cord lecture. You have your dorsal root, where your sensory nerve fibers enter the spinal cord, and your motor root or anterior or ventral root, where motor nerve fibers come out of the spinal cord and goes to the body, and you have your trunk here, where motor and sensory nerve fibers meet and they go as a package together through ramus. This ramus may either go to upper limb or lower limb or any other parts of the body. So if the lesion is present in the dorsal root, the lesion in the dorsal root are of two types. If the lesion is an irritating type, then the patient will have clinical features such as hyperesthesia, hyperalgesia and hyperreflexia. So the another type is destructive lesion. We will discuss this later. Hyperesthesia means increased sensitivity to sound, sight, taste, touch and smell. Hyperalgesia means increased sensitivity to pain. Hyperreflexia, you know, the overactive over-responsive reflexes. Increased sensitivity to sound means even a small increase in the noise outside will cause irritation to the patient, and the same goes for sight. A small increase in brightness, it will be irritative to the patient. Increased sensitivity to pain means even the patient will be very sensitive to pain. Even normal pinch in the patient skin, it will cause immense pain, increase in the pain. Then we will discuss this destructive lesion. If there is a destructive lesion in the dorsal root of the spinal cord, the name itself self-explanatory, destruction. There will be complete anesthesia. Why complete anesthesia? Because the lesion is of destructive type, so it will block all the sensory nerve fibers entering the spinal cord. Block means it will block the information carried by the sensory nerve fibers. So in destructive lesion there is deafferentation. So what is this afferent? Afferent means the information from the body going to the brain. Efferent means the information from your brain to the body. So deafferentation. So in destructive lesion type there is complete loss of dorsal column sensations, anterolateral column sensations. Why dorsal column and anterolateral column sensation? Because the sensory nerve fibers, the informations are blocked here. Further it will not go to dorsal column or anterior column or lateral column. So the clinical features will be respective to the loss of sensations or the respective location. In the next case, there is a lesion or a virus in the dorsal root ganglion. So if there is a virus in the dorsal root ganglion, the patient will have itching, hyperalgesia, hyperesthesia and may also have vesicles in the level of thoracic 5 to thoracic 10 dermatome. That is the skin at the level of thoracic 5 to thoracic 10 dermatome, the patient will have these clinical features. This condition is known as herpes zoster. The next case is a unique case. Here there is a segmenting demyelinating lesions. We have discussed a demyelinating lesion before, that is in the dorsal column syndrome. That is, the patient has a Romberg sign because of the lesion in the fasciculus cuneatus and fasciculus gracilis tract. The next case, there is segmenting demyelinating lesion. This condition is known as Guillain-Barré syndrome. Guillain-Barré syndrome. Guillain-Barré syndrome involve only peripheral nerves. You know, peripheral nerves and central nerves. Peripheral nerves means going to the peripheral body, that is upper limb and lower limbs. Central nerves are concerned with your central nervous system. In Guillain-Barré syndrome, it is considered as a post-infectious polyneuritis. Post-infectious polyneuritis means there was an infection before this syndrome. That infection may be of respiratory or gastrointestinal or tract in origin. If there was an infection, there should be immune system reaction. That immune system reaction, it will attack the squam cells. So where do you see the squam cells? Squam cells are present in the nerve fibers. Why the immune system attacking the squam cells? Because the squam cells they have the similar function and structure with the microorganism which is causing the infection. So basically the immune system, it mistakenly it will attack the squam cells instead of the microorganisms, since it shares this similar feature, and hence causing the demyelination. This is how in this syndrome there will be demyelination. Also note that the nerve fibers coming from the spinal cord going to your lower limbs are longer than the nerve fibers coming from your spinal cord going to your upper limb or your upper body. So if the nerve fibers are very long, then these nerve fibers will also have a rich myelin sheath, that is protective covering of the nerve is myelin sheath. If there is a rich myelin sheath, the infection, the microorganisms, it will attack the rich myelin sheath nerve fibers first. So basically in this syndrome, the clinical features or the demyelination, it starts from the lower limb. Then once the syndrome, if not treated, it will progress, it will worsen, then it will move to the abdomen, then to the thorax. So this is known as ascending fashion, that is from the lower limb and upwards. And also note that both the nerves, that is sensory nerve fibers and motor nerve fibers, are affected, but dominantly motor nerve fibers are affected more than the sensory nerve fibers. And that's why in clinical future there is symmetric ascending paralysis. Symmetric means if right leg is affected, left leg will also get affected. Ascending paralysis, ascending means from lower limb, then abdomen, then thorax, then upwards. So this way is known as ascending. Paralysis, you know what causing the paralysis? Because of the demyelination, and which cause disturbances to the lower motor neurons. And also see here, there is dura mater covering your spinal cord. Inside the dura mater you have cerebrospinal fluid, and if a nerve fiber is attacked by the immune system, usually if there is an fight between the immune system and the microorganisms, there will be inflammation. So this nerve fiber will also have inflammation, and this inflammation may also spread to the dura mater, because the nerve fiber roots are located in the subarachnoid space, which is in the near the dura mater. So if there is a inflammation here, this inflammation may spread lightly to the subarachnoid space. So there will be release of inflammatory particles in the cerebrospinal fluid. Note that the inflammation here is not severe, because it's just a spread of inflammation from the actual site. So in this patient, if the patient go for a lab checkup, there will be a lab checkup of the cerebrospinal fluid. This cerebrospinal fluid is taken through lumbar puncture method. In cerebrospinal fluid of this patient, there will be increased albumin level. So what is this albumin level? This albumin are the inflammatory proteins that are released into the cerebrospinal fluid. And also in this patient, the cerebrospinal fluid will have normal inflammatory cells. Please note that if there is an infection to the central nervous system, that is to your meninges of your brain or any part of your brain, if there is an infection, there will be increased high level of albumin level proteins, and also there will be increased inflammatory cells. But here in this patient there is normal inflammatory cells but increased albumin level. It is because the inflammation is not severe, it is milder one. So Guillain-Barré syndrome does not involve the central nervous system. It involves only the roots of the nerve fibers that are located in the subarachnoid space. So in this syndrome, the cytology, it is called as albuminocytological dissociation. You can see this cytology only in this syndrome. Guillain-Barré syndrome is a non-recurring disease. That is, if it is occurred once in a patient, it will not reoccur again. Then in the next case, the lesion is in the dorsal root and ventral root. That is, the lesion is in the sensory nerve root and also in the motor nerve root. This condition, it is known as Charcot-Marie-Tooth, also known as peroneal muscular atrophy. Why peroneal muscular atrophy? Because in this condition, the lesion, it will attack mostly the peroneal nerves in the lower limb, and because of the lower motor neuron lesion, there is muscular atrophy. That's why the name peroneal muscular atrophy or Charcot-Marie-Tooth. This condition is the most common hereditary peripheral polyneuropathy. Hereditary, the patient will have a family history. Peripheral, Charcot-Marie-Tooth condition only involves peripheral nerves and not central nerves. Polyneuropathy because it involves both the sensory nerve root and motor nerve roots. Then we move on to the next case. In the next case, there is a lesion in the motor nerve fiber. This lesion is of irritative type, that is, it is an irritating lesion. So there is irritating lesion in the motor nerve fiber. This irritating lesion will cause spasticity. The patient will present with a clinical feature of spasticity, commonly around lumbar region. You know, C, T, L, S, this lumbar region. Please note that if there is a irritating lesion, then there will be increased action potential. If there is a destructive lesion, then there will be decreased action potentials of the nerve fibers. In irritating lesion, there is increased action potential. Because of this increased action potential, the patient has spasticity, that is increased stiffness, or we can say hypertonia and hyperreflexes, etc. Then we move on to the next case. This is the picture of the spasticity. There is increased retention and rigidity, stiffness of the upper limb and lower limb. In the next case, there is intervertebral disc herniation. So what is this? What is the function of this intervertebral disc? Shock absorbent. When you lift some weights, when you do an activity, the shock passing through your body, it is absorbed by this intervertebral disc in the spinal cord. That's how the body protects the spinal cord from any damage. So this is a picture of your vertebral body, and here is your vertebral canal. Inside the canal you have spinal cord located, and in the vertebral body there is an fibrous collagenous ring known as annulus fibrosus. Inside that is nucleus pulposus. Nucleus pulposus are remnants of notochord. Usually in these patients, the fibrous collagenous ring become weaker, commonly posterolateral side, that is this fibrous collagenous ring, they will become weaker, and they will grow or they will move backwards and lateral side of the vertebral body. So if the border is weakened, then the nucleus pulposus will also move in this way with the annulus fibrosus. So when this fibrous collagenous ring, when it goes backwards and on lateral side, they may obstruct or give disturbances or block the sensory nerve fibers and motor nerve fibers, or they may disturb the trunk or ramus from the spinal cord. In this way, the patient will present the clinical features. This disc herniation, it commonly happens around your cervical vertebrae and lumbar vertebrae, dominantly around lumbar vertebrae. That is 90% happens around lumbar vertebrae and 10% happens around C6, that is cervical vertebrae. When I say around, it means C5, C6 or C6, C7. When I say around on lumbar vertebrae, it means L4, L5 or L5, S1. Since you have C7 vertebrae, T12, L5, S5 and C4. So the patient will present with the problem of severe chronic low back pain, leg pain, paresthesia, there will be sensory loss, hyperreflexia, motor fibers affected, and the patient will have spasticity and flaccidity. In the next case, the problem is not with the disc, but the problem is with the vertebral bone. That is, in the bone there may be abnormal formation of osteophytes or deposition of abnormal bone densities, which will grow and obstruct the nerve fibers or the trunk or the ramus from the spinal cord. So this condition is known as cervical spondylosis with myelopathy. What is a myelopathy? Myelopathy means pathology related with the spinal cord. Why cervical? Cervical means the degeneration that commonly happens around cervical vertebrae than the lumbar vertebrae. In the disc herniation, 90% it happens around lumbar vertebrae than the cervical vertebrae. It happens on both the vertebrae, but the dominant is lumbar vertebrae. Here in the spondylosis, the most commonly involved is cervical vertebrae, then the lumbar vertebrae. And know that this is the most common condition, comes under the type of cervical spondylosis leading to the myelopathy, that is pathology of the spinal cord. In this condition, the patient present with a painful stiff neck, arm pain and arm weakness. Please note that all the nerve fibers, sensory nerve fibers, motor nerve fibers are also affected, and such a way you have cortical spinal pathway from your brain to your spinal cord, that is your upper motor neuron also affected. Then you have your clinical features according to that. Please note that the cervical spondylosis with myelopathy condition, it commonly occurs around cervical vertebrae than the lumbar vertebrae. So here is the location of cervical vertebrae and here is the location of lumbar vertebrae. Cervical vertebrae most commonly involve your upper limbs, lumbar vertebrae most commonly involve your lower limb. But here the lesion is at the cervical vertebrae. There is a degeneration of the cervical vertebral bones. So what happens is both the lower motor neurons the sensory nerve fibers go entering the spinal cord, and the corticospinal tract, that is the upper motor neuron, all are affected. But here in the lumbar region or sacrum or coccyx, which involves lower limbs, the lower motor neuron or the sensory nerve fibers entering the spinal cord are normal because there is no lesion. But know that the corticospinal pathway, that is the upper motor neuron, is from your brain to the spinal cord. So there is a lesion in the cervical vertebrae, so the information is blocked here. The information, it will not go further down. So your lower limb will have upper motor neuron type of problems. Your upper limb will have lower neuron type of problems. You may ask, why upper limb do not have both the lower motor neuron type of problems and upper motor neuron type of problems? Please note that the information carried by the upper motor neuron, that is corticospinal tract, it will give the information to the cervical vertebra, and there is a region around cervical vertebra. So the information is supplied to the cervical vertebrae. Only the information is stopped beyond the cervical vertebrae. That's why there is no problem with the upper motor neuron in your upper limb. Only there is lower motor neuron type of problems.